This is the second part of the GI lecture. The liver is the largest organ in the human body, excluding the skin. It is one of the most important because it has many jobs, including changing food into energy and cleaning alcohol and poisons from the blood. The liver makes bile that helps with digestion. There are many kinds of liver diseases. Viruses that can cause some are like hepatitis A, B, and C. Others can be results of drugs, poisons, or drinking too much alcohol. If the liver forms scar tissue because of an illness, it's called cirrhosis. And jaundice or yellowing of the skin could be a sign of liver disease. Liver function tests would include serum aminotransferase, the AST, the ALT, and the elevated levels usually indicate cellular damage to the liver. Greater than 70% of liver cells may be damaged before the liver function tests become elevated. Pigment studies, like serum bilirubin direct, serum bilirubin total, or urine bilirubin. These studies measure ability of the liver to conjugate and excrete bilirubin. Abnormal results are seen in liver and biliary tract disease. Another test is serum ammonia. The liver converts ammonia to urea, and the ammonia rises in liver failure. Protein studies, the serum albumin. Low levels are seen with liver disease. Serum globulin. Elevated levels are seen with advanced cirrhosis and chronic active hepatitis. Tumor marking. Alpha-fetoprotein is increased and seen with hepatic carcinoma. Prothrombin time. This is the time required for a firm fibrin clot to form. In liver dysfunction, increased clotting time increases the risk of bleeding. Many patients may not understand end-stage liver disease, whereas cirrhosis may be a more common term. Cirrhotic livers have a cobblestone-like appearance, and although most are shrunken, some may be larger than normal, but all are hard on palpation. End-stage liver disease is a chronic degenerative process which is replacement of the normal tissue with the scar tissue. And there are three types: alcoholic, which is the most common, post-necrotic, from acute viral hepatitis, or biliary, such as chronic biliary obstruction and infection. Other causes include toxic drug or chemical reaction. Clinical symptoms include liver enlargement, ascites, infection, peritonitis, varices, edema, vitamin deficiency, and mental deterioration. Treatment is no alcohol and a well-balanced diet unless they have hepatic encephalopathy, which that case you need to restrict protein, or if they have ascites, then you need to restrict sodium. They will also need vitamin supplements such as B complex, folic acid, and A, C, and K. Complications include portal hypertension, ascites, hepatic encephalopathy, and esophageal varices. Portal hypertension is abnormally high blood pressure in the portal vein, which supplies the liver with blood from the intestine. It may be due to increased blood pressure in the portal blood vessels or resistance to blood flow through the liver. Portal hypertension can lead to the growth of new blood vessels called collaterals that connect blood flow from the intestine to the general circulation, bypassing the liver. When this occurs, substances that are normally removed by the liver pass into the general circulation. Symptoms of portal hypertension may include ascites or esophageal varices. The most common cause of portal hypertension is cirrhosis. Cirrhosis results from scarring of the liver injury caused by hepatitis, alcohol abuse, or other causes of liver damage. In cirrhosis, scar tissue blocks the flow of blood through the liver. Other causes of portal hypertension include blood clots in the portal vein, blockages of the vein that carry the blood from the liver to the heart, and from a parasitic infection called schistosomiasis. Portal hypertension is an increase in the pressure within the portal vein, which is the vein that carries the blood from the digestive organs to the liver. That increase in pressure is caused by blockage in the blood flow throughout the liver. And usually this blockage is caused by cirrhosis, the scarring of the liver, which is a result of chronic liver disease. Increased pressure in the portal vein causes the development across the esophagus and stomach of large veins called varices, and they bypass the blockage. Varices are fragile and can bleed easily. The onset of portal hypertension may not always be associated with specific symptoms that identify what is happening in the liver. But if the patient has liver disease that leads to cirrhosis, the chance of developing portal hypertension is high. The main symptoms and complication of portal hypertension include gastrointestinal bleeding, black tarry stools or blood in the stools, vomiting of blood due to spontaneous rupture, and hemorrhage from varices. The patient can develop ascites, which is accumulation of fluid in the abdomen, encephalopathy or confusion, forgetfulness caused by increased ammonia levels. Patient could experience reduced levels of platelets, which help to form blood clots, or white blood cells that help fight infection. Symptoms of portal hypertension are not evident unless bleeding from collateral blood vessels or ascites occurs. The patient may have striae and distended veins over the abdomen due to the increased abdominal girth from the ascites. Fluid and electrolyte imbalances and respiratory difficulty may occur due to the pressure on the diaphragm. Treatment for portal hypertension is to treat the underlying cause. Treat the ascites, possibly a sodium and fluid restriction, diuretic agents like aldactone or furosemide, albumin therapy, or paracentesis. So looking at this picture with someone with ascites, you can see why the distended abdominal cavity could cause discomfort and shortness of breath. Causes of ascites can come from liver cirrhosis, alcoholic hepatitis, chronic hepatitis, or obstruction of the hepatic vein. This is an accumulation of fluid in the peritoneal cavity. Decreased albumin levels can cause decreased oncotic pressure, and the fluid leaves the plasma and leaks into the peritoneal cavity and interstitial spaces. Decreased volume causes activation of the renin-angiotensin system and sodium and water retained in attempt to return intravascular volume to normal, which then causes more edema and increased ascites. As with any treatment options, prognosis, goals of care, and the benefits and burdens of any treatment is looked at how it supports the patient's goals. Treatment options that are based on prognosis could include sodium restriction of 2 grams per day, administration of potassium-sparing diuretics such as spironolactone, or a paracentesis. A paracentesis is a puncture of the abdomen for removal of fluid. A thoracentesis is a drainage of fluid from the chest. Hypotension could occur for 2 reasons. Bleeding will make the blood pressure drop, and ascites will also make the blood pressure drop. Ascites can make the patient hypovolemic. So it does make sense to check the blood pressure to make sure that they are not shocky already. They look like someone who is in fluid volume excess, but the fluid is not in the right place. It's in the wrong space, and that's why they call it third spacing. The system on the left is called a peritoneal venous shunting and has been known to help increase effective blood volume, increasing the renal blood flow, retaining the nutrients and improving nutritional status, and increasing diuresis. It helps improve mobility and respiration and relieves massive refractory ascites. For these patients, they would lie on their back and they would grasp the pump chamber between their thumb and their forefinger. And you can see it here on the right side of the patient near the lower part of the ribs. It's important that they would pump the shunt 20 times twice a day, once in the bedtime and again when they get up in the morning. The one on the right is called the Pleurx system, and this uses a disposable vacuum bottle to actively draw ascites through the indwelling Pleurx peritoneal catheter. The vacuum bottles enable rapid drainage through a closed system, helping ensure patient comfort, safety, and compliance. Patients now can manage some of these symptoms through smaller or more frequent drainages at home without having to come into the hospital every time they needed to have fluid removed. Some patients may need to have a liver biopsy. The patient will be placed on their right side with a pillow under the costal margin and kept on bed rest for several hours to decrease the risk of bleeding. Anytime you see a liver question, be concerned about hemorrhage. When they have liver problems, you want to decrease the dosages of medication because many times they may not be able to metabolize it. This is why you do not give acetaminophen. Now remember, the antidote for acetaminophen is Mucimus. It comes in a very small vial and it's a clear solution, but you got to mix it with a carbonated drink because it smells really bad. Next, you want to be able to review their coags, their PT, their PTT. Get those vital signs so that you can be concerned about whether or not they have hemorrhaging. It is important to get your baseline vital signs. They are supine with the right arm behind the head is how you would position a patient for liver biopsy. The physician will tell the patient to exhale and hold because you want to get the diaphragm out of the way and you don't want to puncture the diaphragm. It only takes a couple of seconds to actually put the needle into the liver, and they can do this procedure even if the patient is on a ventilator. Afterwards, you'll need to take a blanket or towel and roll it up and hold it on the site to put more pressure. The patient is at risk for hemorrhaging. If someone is beginning to hemorrhage, that blood pressure will go down and the heart rate will go up. Some hospitals might have a sandbag and they'll have the patient lie on their right side because they're putting their body pressure and the sandbag to make sure that that site doesn't bleed. Hepatic encephalopathy. Patients can have impaired neurological function that occurs with profound liver failure. It's an accumulation of ammonia and other toxic metabolites. Other factors unrelated to increased ammonia levels could be dehydration, surgery, medications, sedatives, tranquilizers, analgesics. Now the symptoms at a stage 1 would be a normal level of consciousness with periods of lethargy and euphoria. They have a slow thought process and some slight confusion. They might even have a reversal of their day-night sleeping pattern and have clinical signs of ascites, which is a flapping tremor of the hand, impaired writing, and they could still have at this point a normal EEG. Stage 2 is that they're disoriented. They sleep most of the time but easily aroused, agitated, mood swings. Ascites is present, fetor hepaticus, which is a musty odor to the breath, and an abnormal EEG. Stage 3, they're in a deep sleep, difficult to arouse, incoherent speech. Clinical signs are increased deep tendon reflexes, rigidity of extremities, and markedly abnormal EEG. Stage 4 is comatose. Treatment is to restrict the protein intake in the early stages. Lactulose is given to reduce serum ammonia through bowel movements. Fecal flora are changed to organisms that do not produce ammonia from the urea. Make sure that the sedatives, tranquilizers, and analgesics are de-seeded. Sometimes jaundice is caused by a breakdown of a large number of red blood cells, which occurs in newborns. Sometimes jaundice is the first sign of liver disease. The yellow discoloration of the skin and whites of the eyes are due to the abnormal high levels of bilirubin in the bloodstream. Urine is usually dark because of the bilirubin excreted through the kidneys. There are limited options for drug therapy. Vitamins and nutritional supplements can be given, antacids, albumin, potassium-sparing diuretics, vasopressin for the varices. Only intermittent analgesia if absolutely needed. Dexamethasone may help appetite and pain, and all treatments, usually at end stage, is palliative, and aggressive management of symptoms is important to enhance the quality of life. The primary goal of treatment is reduction of clinical symptoms and prevention of complications to increase comfort. Some patients may require stronger diuretics, such as furosemide. Symptoms of late-stage disease include the respiratory, which is hypoxia from fluid in the lungs and weak chest expansion. CNS effect is lethargy, asterixis, peripheral nerve damage. Hematologic, nosebleeds, easy bruising, anemia. Skin itching, dryness, poor tissue turgor. Hepatic jaundice, enlarged liver, ascites, renal insufficiency, fever, bleeding from esophageal varices. Patients with a slow chronic bleed are likely to be anemic as evidenced by a low hematocrit and may experience physical symptoms such as fatigue, shortness of breath, activity intolerance, and pale in color. Anemia also decreases hepatic oxygen supply, causing damage to the hepatocytes. The late symptoms of cirrhosis can be attributed to chronic failure of liver function. The concentration of plasma albumin is reduced, leading to the formation of edema. The fibrotic changes in the liver cause development of collateral vessels, which then can form the varices and the hemorrhoids. Many patients and families face the disappointment of not receiving a transplant after months to years on a waiting list, while others must confront the devastation that arises when a transplant fails. Recognition of grief and loss should include referrals to counseling resources. Here is a concept map for impaired liver function. So for a nursing diagnosis, you want to observe for potential bleeding complications. You're monitoring the labs, the PT, INR, and the PTT. The diet would be a low sodium, low fat, low protein, small frequent meals, supplemental vitamins. If the serum sodium is low, the patient will be put on a fluid restriction. Medications are given sparingly to prevent liver toxicity. Diuretics are to monitor for hypokalemia and hypotension, H2 receptor antagonists for stress ulcers, lactulose to promote excretion of ammonia via the stool, and neomycin and metronidazole removes the intestinal bacteria which produce the ammonia. Also, monitor the platelets. End-stage liver disease can happen very quickly, also called fulminant hepatic failure, which is sudden and severely impaired liver function in a previously healthy person. The liver failure occurs within 8 weeks of the first clinical sign, and viral hepatitis is the most common cause. Other causes include acetaminophen, chemicals, and Wilson's disease, which is a copper buildup in the liver. As part of the assessment for liver failure, assess their level of consciousness, cognitive level, and orientation. Monitor restlessness and agitation, assess their neurosigns, deep tendon reflexes, and ability to follow directions. Provide a safe environment to prevent falls. Stimulate and orient patient frequently and avoid restraints. Monitor meds such as hypnotic, sedatives, and analgesics, and monitor the ammonia levels. Body image could be an issue. Encourage the patient to verbalize reactions and feelings regarding changes and assess their coping strategies. Encourage and assist the patient in making decisions about their care. Identify resources to help the patient, such as clergy, counselor, or social worker. GI bleeding. Monitor the vital signs, level of consciousness, stool, and emesis for occult or frank bleeding. Monitor hemoglobin and hematocrit, and avoid activities that increase intra-abdominal pressure. Activity intolerance. Assist with ADLs and hygiene, and encourage rest. Elevate the head of the bed during meals to increase comfort. Administer medications prescribed to reduce ammonia, like lactulose. Assess the skin for a degree of discomfort related to pruritus and edema. Keep the fingernails short. Provide frequent skin care, because skin care will remove the waste products deposited on the skin.